Hi, welcome to Fridays with Feldman. We are back today to discuss hip pain in adults mostly. And I'm here with Dr. Zachary McVicker, who's my partner at West Palm Beach, Florida at the Paley Institute. Between the two of us, we really treat the full spectrum of hip disease and hip pain in both adults and children and adolescents. I think because of that, we really wanted to review with you today some of the common causes of hip pain and some of the modern treatments for them. Hip pain, when I started practice 25 years ago, was basically thought to be, a muscle strain, and just live with it and take some anti-inflammatories and do some exercises and you'll feel better. But that's not the case. There are very specific reasons why you have people suffer from hip pain, and they don't have to be suffering. So I'm going to go through some complex stuff about osteotomies, which means when we break bones, and Dr. McVicker is going to talk about the sports related and also some of the evaluations of hip pain in adults and adolescents. So there it is, basically Fridays with Feldman, September 23rd, 2022. So I'm going to give it over to Dr. McVicker in 1 second. But basically, hip pain can be from many different causes. You can overuse it maybe by playing golf, maybe especially in Florida. You can have some trauma when you're doing something, either from a car accident or just by playing sports or running around. A muscle pull. You could have an arthritic hip and maybe need a hip replacement. You could have a tear inside there, like a meniscal tear of the knee. You could tear the inside of the joint. And then I'm going to discuss some things. You can have shallow hips and hip impingement. So Zach's going to talk about those right now, and I'm going to give it over to him to speak about some specific conditions.
Thanks for having me on. So even now, you just alluded to how in the past, how patients would come to the office and people would kind of say, there's not much we can do for you. So now, it still happens, and there's just more avenues to get to the right people. And a lot of patients will present and they'll say, hey, it's been a hip flexor my whole life. My trainer's always been telling me it's my hip flexor. It's more than that, typically. So one of the more common things that I see is called femoral acetabular impingement, or FAI, hip impingement. So there's a couple different types. One where you can make a bump on the femoral head, so it should be a nice smooth ball like a light bulb, and sometimes you get a little bump here and it makes it a little asymmetric. So when you have that asymmetry on the ball, it starts to create problems in the labrum, in the cartilage, and can delaminate the cartilage, meaning peel it back over time, and that can lead to arthritis. There's another type called a Pincer Infringement, where the cup overhangs the ball too far, and you get a similar kind of reaction where you're crushing the labrum and causing pain in the groin, the hip.
And do patients mostly get that with sitting or standing? What do you find?
They get mostly with sitting and squatting and going into deep hip flexion type activities. And
right, so, I find people coming to my office often with that and telling me that exactly what Zach just said. Their pain has been there since they were in high school, and they're now 40 years old, and they're just told to live with this pain, but it's gotten so bad they can't live with it anymore.
And so this typically, patients present to us around 25 to 40 years of age. There's patients on both sides of that age range, but that's typically when they present and they show up to us. So most people will have groin pain with a labral tear and impingement. They'll have groin pain, but you can also have lateral hip pain. You can have some buttock pain too that is referred over to there. So like we were saying that a lot of the activity, the sitting, the deep hip flexion, things like that will cause more pain in the groin. So this is an MRI kind of showing this asymmetry here, where you have this big cam lesion, and it should kind of match the curve down here. And you can see how large this is here, and then you see a labral tear on the other arrow here. So this is just another couple of views of a hip with a torn labrum. You can see right here is the labrum, and you can see fluid moving in between the labrum and where it's supposed to attach on the bone.
And that's one thing I think is important for people to know. I agree, is that sometimes, and Zach was just alluding to it, when you talk about groin pain or hip pain, it's very hard to know where your pain is when you have pain in a joint. It doesn't mean that you can specifically point out where your tear of your labrum is. Just basically general discomfort around the hip is hip pain. So you don't have to be it's not as specific as you think it is for the pathology. I'm always surprised that, I've had knee pathology or knee pain, and it doesn't mean that I know exactly, where that hip pain is.
So what I perform with when people present with labral tears that are failed non-operative treatment, and that typically happens because this is a structural problem. It tore for a reason, usually because of the bony contact. So typically this leads to surgery, and the minimally invasive form of this is hip arthroscopy. And as you can see here, this is a portion of the surgery where you see the cup, the acetabulum here, the ball, the femoral head here, and these are the cartilage surfaces, and those look good. And then you have the labrum here, which has undergone a repair. And this is a little instrument coming out here. So you're looking in through small incisions, less than a centimeter, with camera and specialized instruments to take care of that labrum. And then you can also take care of that bony contact for the most part, the typical presentation for impingement, the cam lesion, some of the pincers and things. But when they get to other kinds of bony morphology, meaning a little bit shallower cup and things like that, which we'll talk about in a little bit, it needs a little bit more help with osteotomies and such. So this is what you would see on a labral tear. So again, your labrum up here. This is the ball. The cup is back here. You see kind of this crab meat hanging down. That's part of the labral tear, and that can cause significant pain because the labrum has nerves. It has sensation in it. It gives you proprioception, meaning balance and sense of where you are in space. So when you tear this, you can start to have pain in the groin. Like you said, very non-specific, but it's there and with certain movements. And then sometimes when the labrum is just not repairable, we can make you a new one with a cadaver graft, meaning a graft from another person, and really restore that function of the labrum, which is the suction seal of the hip. There's other types of impingement, not just the FAI, but there's something called ischiofemoral impingement, which is in the back of the hip. There's a narrowing of the space that occurs between the femur and your pelvis, and your sciatic nerve goes right down behind those. And sometimes people have a very narrow space for other reasons, like twisting of the bones or the pelvis that causes the space to narrow. It can actually give you a sciatic nerve type pain that travels on your leg, and people will think it's their back for many years, but they never have any back problems. And sometimes this could be one of the causes. So people with trouble running, doing lunges, and get that shooting pain down their leg, this could be an issue. So this is an MRI showing that, and on this side you can see the space is nice and open. There's no fluid, meaning this lighter gray is fluid, and fluid means that it's inflamed and bad. You can see how narrow it is through here, and you can see that white signal in here. So the sciatic nerve is back in here, and it's causing a lot of inflammation around that. So sometimes, if there's no osteotomy needed, sometimes you can go in arthroscopically and you can trim that space and widen it so that you're no longer pinching. Obviously you need a further workup to see if they need an osteotomy, but sometimes this can be treated minimally invasive. Some other things that can cause some buttock pain, you have hamstring tears. So some people will get just overuse type hamstring injuries where it just kind of degrades over time and becomes worn. Other people will pop the hamstring right off the bone. And then sometimes we can treat this arthroscopically, and this is some of the pictures that we have here, bringing the hamstring tendon back up to the bone, and then you have some nice tension on the end and restore its anatomy and function. And one of the more common things I see all the time in clinic is this lateral-based hip pain. So this is something that people call for years and years Trochanteric Bursitis. Changed its name a little bit. It's greater trochanter pain syndrome. When I think of this, I think of it a little bit more of a tendonitis of your gluteus medius, which is a muscle that helps you move your leg out to the side. And it causes inflammation in the area. It causes the bursitis, and there's a reason why you're getting inflamed in that area. And so, working that up and taking care of that lateral hip pain is important, because if you let it go, the tendon starts to degrade, starts to tear off the bone, you have more pain, lack of function. So this here is a view showing the tendon pulling off.
And lateral is the side, just so everybody knows listening, lateral means on the side of your hip, which is probably the most common place people actually complain of pain. This is the most common form that I see as well, and very amenable to some non-surgical treatments as well usually.
Right. So this is a picture of a gluteus medius, that hip abductor tendon that I was referring to, and this is endoscopic, meaning through the small poke holes in the camera view of this. So this is the bone down in here, and you're looking at the tendon up here. And so further pictures on the endoscopy, this is kind of the idea. You're taking the tendon and you're pulling it back down to the bone to restore its function. And so here's a couple pictures of placing suture anchors and bringing the tendon back down, and this is just kind of your end product. Restores that anatomy, restores that tension.
And without that muscle, you do get a chronic limp. So I mean, a limp, even a painless limp sometimes, but a really significant limp, because that muscle is probably the most important one to stabilize your body and to stabilize your pelvis. So I'm going to talk a little bit about some of the, as Zach just finished talking about some of the related things that you can do with an arthroscope, which is amazing these days because that's all new. I mean, many of these things that he was speaking about are being able to be fixed without doing open surgery. I'm going to talk about some of the reasons why sometimes we have to be a little more invasive. And I'm going to talk about that, what I do in terms of osteotomy, which means breaking the bone. So we know that about 50% of people who undergo hip replacements, about 50%, actually had a shallow hip when they were young. And shallow hips can come about for many reasons. If you were a very avid athlete before you reached adolescence, sometimes the hip doesn't develop as it should, or it's genetic. Someone in your family had it before you and it just doesn't develop deeply, and sometimes we just don't know why it's shallow. The ball is just not deep enough in the socket, and that causes you to point load and basically wear out your socket much quicker. And some of these other more rare disease conditions I treat as well, but they're much rarer. So acetabular dysplasia is a fancy term for a shallow hip, and basically it just causes you to develop arthritis at a younger age. And that could be anywhere from 11 to 50 where you become symptomatic, literally. And so that's why one of the questions people are going to ask me is what age? Sometimes the age doesn't matter, it's what the hip looks like that matters. So here's a person with, you can see the point loading on this side, a lot of the ball is uncovered, and basically it's already arthritic, and that's what it should look like. And then if you wait too long, by age 43, this is a destroyed hip, you have arthritis, and you end up with a hip replacement like that. So our goal is to try to avoid, at least if we can, hip replacements. So what are your choices? Well, if you have hip pain, your choices are, if you have early arthritis, you can take some anti-inflammatories, but if you can treat the underlying cause, perhaps that's better. There are some injections these days that we give, something called alpha-2 macroglobulin, that can decrease perhaps the rate of arthritis, how quickly it degrades. But again, it's not curative. Steroid injections should be reserved for very temporary measures in joints. They may actually damage the joints a little bit, so we try not to use them too often within the joints, and you shouldn't have too many of them. But if it buys some time, perhaps in an older person, that's okay. And younger people should try to avoid in the joint injections of steroids, because it's not treating the problem, it's just masking the problem actually. And then we talk about hip arthroscopy, which is often combined. Dr. McVicker talks about that exactly. And it's often combined with what I have to do, because I can do much less invasive surgery if the joint's taken care of first. And we'll talk about how we do some of these other osteotomies. So the periacetabular osteotomy, or the Gans osteotomy, started back in '88, or is published in '88 by Reinhold Gans. And he lived in Bern, Switzerland, which is a picture when I visited him there and watched him out. I spent 3 weeks in Bern, and it's quite an amazing place to visit and to learn this procedure. But it allows us to deepen the socket in a way that we couldn't do that before. And so it's called periacetabular osteotomy. These days it's about a 2-hour procedure in total. It's 1 to 2 nights in the hospital, and it's about 6 weeks on crutches, although sometimes it takes longer to heal. It just depends upon how long it takes the bone to heal. And the incision, this is actually longer than it usually is. It's usually about up to here. And you cut the bone from the inside to allow us to deepen the socket and move. And it's your own bone, and then we hold it with screws. So this is a 37-year-old woman who has activity-related pain. She had an MRI which showed a labral tear. So first, actually, Dr. McVicker fixed the labrum for me about a week and a half before. And then this woman underwent a periacetabular osteotomy. And you can see the uncoverage of the hip on both sides. And actually next week she's undergoing the second side. So she's 37, very active, very fit, very athletic. And and she did quite well and has no pain. And now it's 6 months later, and she'll do the opposite side, and we'll take the screws out of this side. So the screws are there just to hold the bone until it heals in the position that you want it to. There's nothing artificial in her bone, it just heals by itself, and then we can remove the screws very simply, and the hip has no, at the end, there's no screws. This is this is the other spectrum, a 14-year-old high school student, mother had hip dysplasia who I treated, and she has very significant hip dysplasia and couldn't play soccer anymore with hip pain in both sides. So after one side, she had the second side done as well. And again, hip scope before, fix the labrum, and then go ahead and restore the normal anatomy. And she will likely never need a hip replacement, or at least in the next 30, 40, in my 40 years, she will not need a hip replacement for arthritis, because we got there before there was any arthritis at all. And I think that really is the goal for what we're talking about. So, Dr. McVicker showed you hip impingement, so I'm not going to go over that again. There's the cam lesion, the same thing. And today, so I'm reviewing this because this is sort of historical. We used to dislocate all the hips. And I'll show you pictures of that to actually smooth them out, things that he's doing right now with just an arthroscopy. And then sometimes we actually have to, if the hip is shallow after you've gotten rid of the bump, then we actually take the hip and do what's called a reverse PAO, because basically there's so much impingement from the cup that I have to actually get it out of the way from the femoral head. And a surgical dislocation for this is almost never indicated anymore for hip impingement. I think almost all these days can be done with hip arthroscopy. This is a 15-year-old girl I saw when I was visiting Switzerland. She was a cheerleader, and I saw this x-ray, and I thought, as a pediatric orthopedic surgeon, this is a normal x-ray. Take some anti-inflammatories and you'll be fine. But if you really look closely, you can see that there's actually a crossover sign, that basically the hip is crossed over and she's actually impinging. And she had severe pain when she was cheerleading. And then you get the MRI, and maybe you don't see this, but she has a big divot right in her cup. And Dr. Gons called that a herniation, but basically it just looks like it's a bump. There it is, right here. And again, wasn't really that big a believer. And then I saw it inside when they opened the hip up, and there it is. There's the damage to this hip joint, just from bumping it and bumping it and bumping it. And that's really what they can take care of now. Now, we took care of this at that time with an open surgery, but now I can do this with arthroscopy. And so those crossover, that little crossover right there is the problem. And that's what we know today that we didn't know certainly 20 years ago or 25 years ago. We did what's called a reverse PAO, fixed that labrum, and she's fine. And there the lines are now completely lining up. An 18-year-old, and this is, they had a childhood problem, which was called a slip capital femoral epiphysis, and they now have impingement. Dr. McVicker now can do this again with an arthroscopy, but this is looking at the limits of that from inside. If you don't like anatomic figures, turn off your TV now for a minute, or your computer. But basically you see this is a femoral head, and you can see it's very smooth, but there's a bump right here. And that's actually the blood vessels that go into the hip. That's the limit to how much Zach or anybody can do with an arthroscopy, because if you cut that, then the hip will die. So basically you leave that, but you can take away all this that's impinging. And what we're doing now with arthroscopy, we used to do with huge incisions. So there you can see we're taking off the bump that Dr. McVicker would do with a shaver. And there it is bumping. It's Dr. Gons' hands. There it is bumping. And there it is not bumping anymore. It's pretty. So I have some frequently asked questions. I'll go through some stuff and then I'll let Zach finish up with this. But basically, some of the questions I asked are, and I'll start with one they asked both of us, is why don't we do the hip arthroscopy and the osteotomy on the same day? And the reason for, we actually divide them by about 10 days to 2 weeks. And the reason for that is because they are completely different surgeries, completely different setups. And when the arthroscopy is done, there's a lot of fluid in the joint and a lot of fluid around the entire area. And I make a very small incision to do PAOs, and if you did it at the same time, our results have been so good, I don't want to take the chance that you'll get an infection, that the surgery will become more difficult, and the hip will become stiff afterwards. Because you spend the first 2 weeks after arthroscopy really moving the hip. You can't really do that after I cut the bone. So we've had really such good results, and I know certain people say they can do it the same day. Yes, we can. We work in the same operating room. We can do it on the same day. It would be very easy logistically. I don't think it would be very smart for the patient. Okay, what are the questions? Who cannot have a PAO? Who has hip dysplasia? Well, that's an easy one. Someone who has too much arthritis. And that's why we tell people not to wait so long. And there's no age for that. I've done as old as 54, and I've turned down people who are 15. I just say you need a hip replacement. It's just too late. You have too much arthritis already. Why? There's no whys to this. Why it happens that some people get arthritic quicker than others. And then if the hip is not round. If the hip is not round, I cannot put the hip on top. I can't do a PAO. And what age? I just said that I've gone from 11 to 54. And it really just depends on the status of the cartilage, activity level of the patient, and what the hip itself looks like, and can we still fix it. 54 is really pushing it, but that patient did actually very well. When can you return to sports after a PAO? Usually incrementally, but usually about 3 months, 12 weeks. When can someone return to work after a PAO? Well, if you're doing office work, I've had people start working from the hospital bed in the hospital, but certainly they can go back very quickly within a week. If you are driving to work, that's a problem. You may have to use one of the car services because you really can't drive for about 6 weeks. And heavy labor probably for about 3 months. So those questions are really frequently asked questions. They're on our websites. You could certainly look it up, and happy to answer any questions you have. Any closing comments about any of this?
I would just say that when you have hip pain, make sure that you're going to see a hip specialist. There's a lot of horror stories that you hear out on social media and blogs and things like that. That they just didn't recognize the underlying pathology and really didn't take the time to appreciate what's going on and jumped into a surgery that was not indicated. Not that they did a bad job, it was just not right for that patient. So I think going to a team like we have here that can take care of all the issues is of utmost importance, because you know that you're getting the proper surgery and then done well too.
Well, that's Fridays with Feldman regarding hip pain. I hope you enjoyed, and have a great weekend. Thank you.